Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning Abdomen Series.
We're going to have some discussion on the abdomen series before we actually go position our patient for it. Abdomen series that I'm going to discuss today consists of 4 projections: the PA chest, upright abdomen, a supine KUB, and a left lateral decubitus. The abdominal series protocol may change from institution to institution, but if you know those 4 projections, no matter where you go, you should be able to complete an abdomen series. Important to keep in mind with an abdomen series is you need to demonstrate air fluid levels. If there is trauma to the abdomen, the physicians will be able to detect free air or free fluid if they're a problem. And in order to properly demonstrate fluid or air levels, you have to allow time for those components to settle out in the patient. So many times you have to stall 5 minutes in between the projections, maybe even 10 if you need to demonstrate air fluid levels. Usually a patient will arrive to the department on a stretcher in a semi-recumbent position like this. So their chest is already in a fairly vertical position. So we make sure we do our PA chest first. If the patient's had a PA chest earlier in the day, which is a possibility, you would not have to do a PA chest again necessarily. These patients are very, very sick, and sometimes you may end up doing series multiple times during the day. So it's important to note the date and the time on these series. Again, the scenario is the patient arrived in the department on a stretcher in a semi-erect position. So we would do our PA chest first. If the patient's already in a position like this, do your upright abdomen next. And then you would do your supine KUB, and we're not after air fluid levels on the supine KUB. Air fluid levels will be demonstrated on the chest and the upright abdomen. The KUB is for the normal abdominal shapes in a recumbent position, and then the left lateral decubitus is used for air fluid levels as well. Make sure you do a left lateral decubitus. The rationale behind that is the stomach is on the left side, and the stomach naturally has gas in it most of the time. And so when the patient's lying on their left side, the stomach is contained to the lower side of the abdomen, and the air in the stomach would then be contained like it would be in a balloon lower. If there's free air, free fluid, the air will rise and the fluid will settle out, and it will not be confused with the air that's naturally in the stomach. You might end up doing an AP or a PA decubitus, but the patient must be in a left lateral position. We're going to move to our X-ray room now. And by this point in training, you have had ample opportunity to do PA chest. So I'm not going to take the time on the video here to re-demonstrate a PA chest. Let's just go into the scenario that you've already completed that particular part of the abdominal series protocol. So our patient was for a PA chest, and now we're going to have her come and step in front of the board for the AP abdomen. I changed my SID from the PA chest from a 72 to the 40 inches. And I have my patients stand with their feet slightly spread apart so they're stable. MSP will be to the center of the film. And I'm going to lower my board. I'm going to utilize a 14 by 17 ID blocker to the bottom, so they can see that we're going to use an R marker for the patient's right side, and we're using an arrow, an upright arrow. Your department might have a marker that actually says the word upright or says the word perhaps erect. But you need to mark on this film with lead that this is the patient's right side, or you could use a left over here, but you must have an arrow or some indication that this is your upright position. We're going to palpate for the patient's iliac crest. There's her iliac crest, and I have the crosshair right at the level of the crest, and then it's exiting to the center of the film. The average patient, that centering will be perfect. Iliac crest to the center of the film. You cannot clip diaphragms. You must have diaphragms on there. So in the event you have a taller patient, you might be centering a little bit above the crest. To help you know when to make that decision to raise your film or not, I'm going to show you some tricks. You can use the xiphoid process, which is approximately at the level of T9, and if your film's edge is well above T9, you know that you're going to have diaphragms on there, because when the patient takes in a deep breath, the diaphragm lowers and is visible beneath the 10th posterior rib. So I've got plenty of film clearance here, and I'm not concerned at all about raising the film. I want as much of the abdomen on there as I can get without clipping diaphragm. Another trick that techs will use is they will have the patient elevate the arm, and they will look at the top edge of the film with the axilla. If the film's edge is real close to the axilla, again, they will not clip diaphragms. I'll try to mock this with Drea, though, because I don't want you to take for granted that you should center higher than the crest level. But let's say you did take that for granted, and we're just going to center 2 inches higher than the crest to the center of the film. Okay, the center of the film is now 2 inches above the crest. Take a look at the top edge of the film on Drea as our patient. And how much lung are we going to include? I want you to think about that. This projection is after the abdomen. And if you are afraid of clipping the diaphragm, and so you compensate by raising the film, you actually have half of your film over her lung now. And that's what we don't want. So an average patient of height, again, center at the level of the crest, so you get more abdomen on there. But utilize the tricks to image the chest to make sure that the diaphragms are up at the upper level. Now again, I will stress the breathing of the upright abdomen. I just double-checked that the MSP was to the center of the film. She's not rotated. She's facing the board straight. I have a 14 by 17 collimation. If the patient is tiny, you could collimate side to side, but I don't have an excessive amount of collimation, so I'm going to leave the 14 by 17. Then I would give my patients instructions on how to breathe. If it's possible, try for the double breathing technique. Have your patient take in a breath, blow it out, take in another deep breath, hold this one in, do not move, and then you can make your exposure. Then allow your patient to breathe. We utilize a deep inspiration for the purpose of lowering the diaphragm, trying to make sure it gets on the upper edge of the film. If the patient is not rotated, you will have the wings of the ilium equal in width on the two sides. If there's rotation, the side that's closest to the film will actually be wider than the side that's away. Okay? After our upright abdomen, we are going to want our patient to lie down on the table. So we're going to readjust things here. You maintain the 40 inches of SID. Tube is transversely centered. You're going to utilize a 14 by 17 ID to the bottom. No marker other than the R or the L. Patient can lie flat on their back. Both arms down or both arms well above the abdomen. Patient's legs out straight. Get the patient straight on the table. And then you can float your table to have the mid-sagittal plane to the center of the film. and the center of the film is at the level of the iliac crest. Okay, you can see your iliac crest there is right to the center of the film. Now we're not after air fluid levels on the recumbent, on the KUB. So we want the abdomen demonstrated in its full capacity. Therefore, we want to elevate the diaphragms. To elevate the diaphragms, you have your patient take in a big breath, blow your breath out, don't breathe or don't move. So that's suspended expiration. We want the diaphragm raised. When you're looking at the x-rays, you should pay attention to the level of the diaphragms. Okay, we're going to pause the camera now for a minute because we've got to reset the room up to demonstrate the left lateral decubitus. We'll be back shortly. We're continuing with the demonstration for an abdomen series. A few minutes ago I finished the supine KUB. The patient was lying on her back. MSP was to the center of the film, and the center of the film was at the level of the iliac crest. You gave the patient breathing instructions for expiration to raise the diaphragm. And again, anytime you're looking at an abdomen, you look at the wings of the ilium to make sure they're symmetrical in order to know that you were a truly AP position or not. If one wing is wider than the other, that one was the side closest to the film. Right after we made that exposure, I came back into the x-ray room and I asked my patient to turn on to their left side. Drea has been on her left side approximately 10 minutes while I got the rest of the equipment set up. I will have you recall the intro explanation in that when you're demonstrating air fluid levels, there needs to be a chance for those air fluid levels to settle down and to level out in the body. So the patient came to the department already in a vertical mode, and that's why we did the PA chest and the upright abdomen first. But once the patient went into that recumbent mode, the air fluid levels spread out through the body and we would not be able to demonstrate them. So I turned the patient up onto her side the very, very first thing. And by the time I readjusted the room and changed cassettes and set it up like this, it's been about 10 minutes. So let me explain to you what we've done. The patient's on her left side. Again, that's to trap the air of the stomach down so free air can rise. And she's in a true lateral position. Check her shoulders, check her back. Arms need to be up, clearing the abdomen, and her head is resting comfortably on the table. I have a 14 by 17 cassette with a grid, a portable grid placed in front of it. And I'm going to show you how I place the markers here. See the left marker in the decubitus now? Okay, that's what you want to do. The ID blocker is to her caudal end with the L marker and the decubitus on the left side. If you recall, decubitus will let the observer know that we had a horizontal beam. She's in the left lateral position and the beam is horizontal, making it a decubitus. I have got the center of the collimator right to the iliac crest, and I want it exiting to the center of the film. Again, if we're after air fluid levels, we want the diaphragms on there. So I set the film up to have it level with the crest in the center first, but then I look at where my upper edge of the film is. It's close to the axilla, so I know I'm not going to clip diaphragm. You can also palpate a rib here, and this is probably her 11th rib coming down, so the 10th is here. You can see you have plenty of clearance above that 10th rib. So I'm not going to adjust the film higher because this patient does not dictate. But a 6'1" person, you may set it up to the center of the film to the iliac crest. But if you don't like the edge placement here, if you have not included enough lungs, you may have to shift it 1 or 2 inches higher than the crest being to the center of the film. When we do a decubitus, you still want to maintain your 40 inches of SID. Measure from about 1/3 of the way into the tube housing over to the grid wall. Andrea, would you turn the light on for me again, please? Thank you. And this crosshair here is 7.5 inches up because the grid, the cassette holder is actually, the film is 14 by 17, but the grid itself is actually 15 by 18, and half of 15 is 7.5. So we look at the level of the collimation here, and we have it coming in right across at the 7.5 inches. Okay. If we're after air fluid levels, we want diaphragms included. How do you help to ensure that diaphragms are included? It's a breathing technique. What do you think that might be? Suspended inspiration. Have your patient take in a deep breath, blow it out. Take in another deep breath, and hold this one in, please. There you go. Last thing we're going to talk about is technical factor adjustments. And with Drea in this lateral position, I want you to think, when she was flat on her back, her tissue just kind of laid out this way, gravity, it just laid that way. When a patient turns onto their left side, gravity, the tissue will go closer to the table. It depends on the habitus of the patient, size, and muscle conditioning. But sometimes tissue really drops. Air fluid levels are going to rise. They're going to be on her right side. So from a supine KUB, if you needed 30 mass, 40 mass for the supine, there's a rule of thumb that you drop the amount of mass for the left lateral by about 30%. Okay? Again, that's because the tissue drops and this part of the body becomes less dense. In an upright position, you may need more mass because when the patient stands up, the tissue tends to go like this, becoming denser. You want to pay attention to your post-exposure readout so you do know how much mass is being used on these. Pathological conditions can really play havoc with your technical density because if the patient has a lot of air, the tissue density will be easily penetrated. If there's a lot of fluid in the abdomen may not be bigger, but it's definitely more dense. So many times, it's unfortunate, but you'll be repeating some of these films, not for positioning reasons, but because of technique reasons. When we look at a decubitus film, when you look at the density, again, look at more of the right side. This side may tend to be darker, that side may tend to be lighter. This is the important side because you're looking for air to rise. And if she's in a true lateral position, the spinous process of the vertebrae will be in the center of the vertebral body, and the wings of the ilium, again, will be symmetrical, and they will look even on both sides. And Drea, do you have anything to recommend? That's the conclusion of this lesson. Hello, class. We've set the room up today to demonstrate a decubitus chest. A routine chest has been performed in the near past, and they're suspecting some type of pathological condition. There might be fluid involved, there might be air involved in the lung. Decubitus chest means it's a chest, patient's lying on one of their sides, and you have a horizontal beam. So let's just take a look at the setup here. You can see that the tube is shooting horizontally across the table. I have my 40 inches of SID. We've shown you this before when we've done the abdomen series. You measure a third of the way into the tube housing to get 40 over here to the grid. I have a 14 by 17 cassette with a portable grid face. And in this setup, the marker is actually the ID blocker, the patient identification blocker is superior, and it actually ends up being closer to the table, but we want it above the apices of the lungs. Patients in a true lateral position, you need to validate that she is by feeling the shoulder blades and the small of her waist to make sure she is in a lateral position. The film's edge is 2 inches above her shoulder. It's difficult to tell that positioning the patient or perhaps to visualize it on the camera. So here's the trick that you use to position the patient. You feel for the cervical prominence, the most prominent point of the cervical spine region. That's C7. They call it the cervical prominence. When the patient's arms are in a natural position, C7 is at the level of the shoulders, the height of the shoulders. So we're just going to find cervical prominence. It's right there, and we make sure that the film's edge is 2 inches above. And again, you have your crosshair of the cassette at the 7.5 inch mark, because you want this crosshair to the center of the grid. Film's edge is 2 inches above the cervical prominence, and the central ray is exiting to the center of the cassette right here. Collimation is within the film's edge, right here, and lower. And the trick that you can use to make sure you're too not wide, if you see light on the wall, you have your too wide of collimation. So bring it down. Okay. I've got her shielded because I am protecting the reproductive organs. And positioning-wise, I have everything set up that I would need to do. I'll show you the marker placement in just a second. But since she's all positioned nice, again, 40 inches SID. She's on her right side in this scenario. And take a look right down here. She's actually on a blanket, or what you could use as a pad. And the cassette is not up on the pad. The cassette is lower than the pad. It's flat on the table, and the cassette is close up against the patient's body. Patient is straight in a true lateral position. Again, film's edge is 2 inches above the cervical prominence. And then you can have your patient take in a deep breath, blow their breath out, take in another deep breath, and hold it in. And this would be the positioning for a decubitus chest. In this setup, I'm doing a right lateral decubitus. So I'm just going to take the setup apart for a second. And this was the relationship of the cassette, and I want you to pay attention to the marker placement. I have a right marker and a decubitus up by the apices of the lungs, and the ID blocker of the cassette was up near the apices of the lungs. Rationale behind that is the apices of the lungs will be narrow, and the lung flares out for costophrenic angles. And if you put markers down here, you might be in danger of putting the marker into pertinent anatomy, the costophrenic angle. The reason the patient's built up onto a sponge is to elevate the downside so it's higher than the cassette edge to make sure you get all anatomy on there. So when you're doing a decubitus chest, you must build the patient up onto a sponge. Therefore, make sure the cassette is not up on the pad. The cassette goes down flat on the table, and the patient is built up a ways on the pad. With her chest in this position, she's in a right lateral position. If fluid was of interest, I want you to think about this for a minute. Fluid settles and air rises. I am interested in this scenario in a right side condition, and fluid, I put the right side down. If I was concerned about right side pathology and I was concerned about demonstrating air, what lateral would you take, keeping in mind that air rises? If I did a right side for air, the air would rise like this, be trapped by the pleural cavity, and air would be obscured by the spine. So if I was doing a right side for fluid, I would actually have to do a patient in a left lateral position because I'm after the right side, and fluid would rise and the spine would not obscure it in that way. Most of the time the requisition will let you know whether they want to do a right lateral or a left lateral, but the registry may not, or you just may have some kind of indication that they're concerned with the amount of fluid or the amount of air that's in the pleural cavity, and you need to think this through, critically think it through. Again, if you're after demonstrating fluid, the affected side should go down. If you need to demonstrate air, the affected side would be away from the film. This particular room will only shoot the tube shooting this way. And notice how the original setup I was shooting PA, and if I was for right side air, I would be shooting AP. Shooting AP versus PA would not have any significant difference. It would not contribute to a good radiograph or not. Knowing which side you're after and knowing whether it's fluid or air, that's critical. Then you shoot AP or PA, whatever your equipment allows you to do. But just for a review, if we were going to do this in an AP position, we'd elevate the pillow above her shoulders because we don't want to demonstrate the pillow. We want her in a true lateral position and straight on the table. I'm looking at her shoulders and I'm looking at her hips. I would find the cervical prominence. I would put the cassette 2 inches above the cervical prominence, and then I would realign my tube to have 40 inches, to be entering 7.5, and have everything lined up, the tube with the film. In this scenario, it would be a left lateral decubitus, so I would change the right marker to a left, and I would leave the decubitus marker where it's at. Again, the patient is built up on some kind of a sponge. When we turned her onto her side, we actually lost this, but you can see how skinny I folded that blanket. So when it goes underneath her, it elevates the patient underneath her shoulders, all the way up to her shoulders, and then the cassette can drop back down behind it and shield your patient's reproductive organs. And this would be a demonstration for the decubitus chest. If the patient is in a true position, AP or PA, again, you'd look for the sternoclavicular joints to be symmetrical. It's a deep inspiration. That will drop the diaphragm down. Diaphragm should be below the 10th posterior ribs. Make sure the arms are elevated, scapulars are rolled forward. And that's a decubitus chest.